So as we have designed our course, we are ready for the day 8 training, and as ChatGPT says that infectious disease fellowship candidates should learn antibiotic stewardship on this day. And most doctors know antibiotics, but the great ID physician should know when not to start antibiotic, when to stop antibiotic, how to de-escalate antibiotics, and how to prevent resistance. That is the main thing for these days today. So 8 a.m. round, that is known as pre-round. Question 1 comes here is a patient has fever, TLC is 13,000, CRP is elevated. So should antibiotics be started immediately? So you should also know that what is fever, why fever is there in infection, why they have given this TLC 13,000, and what is the significance of CRP. So we will discuss it in the next video, but answer to these questions is not necessarily antibiotics should be started immediately. And if you want to start antibiotics, before that you should ask this question whether is this a infection or colonization. If you know the infection, then you should know the source, because then only you know the site, and then according to that antibiotics may be given. Then have cultures been sent? Before antibiotics, culture should be sent, because after that it won't give the pathogen in the culture. So is patient septic, BP is low, and all those signs and symptoms are there, that means that infection is in the blood. So remember that always fever is not infection, because here fever is there in the patient. So what else can be the causes for possible in fever? Then autoimmune diseases, it may be there in drug fever, malignancy, thromboembolism, pancreatitis. So as ID fellow, we should know that why these type of conditions they give rise to fever, and what is the use of fever, and why we get fever in these conditions. So now coming to the 9 a.m. stewardship round, we should know that what 5 Ds are there. So for antibiotic stewardship, as we all know, these are right diagnosis, a right drug, and right dose, right duration, and de-escalation. So these are the 5 Ds which every ID fellow should know for proper antibiotic therapy. So after that, the case 1 here is a patient with UTI. He is receiving meropenem, colistin, and vancomycin. But in urine culture, we find ESBL producing E. coli, which was sensitive to meropenem. So it was given all these things. So what should be done? Answer: to stop vancomycin and colistin, because it is ESBL producing E. coli. So why to give vancomycin? It is given for gram positives. Then colistin, because it is sensitive to meropenem, so no need of colistin. So continue with meropenem, and reason is treat the pathogen, not the fear. Now coming to the 11 a.m. round, where blood culture we are dealing with. So interpret these two blood culture sets. One is Coagulase negative staph in bottle 2, there is no growth. So question is, it is contaminant or pathogen? We know that if it is this type of scenario, the Coagulase negative staph may be colonizer. So approach is, as central line is present or not. Prosthetic valve immunocompromised. So is there any prosthetic valve? Is there any immunocompromised state? Then single positive bottles usually suggest contamination. Never treat laboratory reports alone, and treat the patient. So coming to the next round, antibiotic timeout, that is at 48 to 72 hours, look for Do culture support the infection? Again you are doing the culture, then you see whether this culture support the infection. Can antibiotics be stopped? Can therapy be narrowed, or it is still IVs required? So this is among the highest yield stewardship intervention, that if it is IV, switch it to oral one. Now after that, for one, you should check for ICU stewardship. Common ICU mistake is that patient is sick, therefore more antibiotics. So it is wrong practice. Question is source control achieved? Is diagnosis correct? Are cultures positive? Is there a non-infectious explanation? Then many ICU fevers are not infectious, so we don't need antibiotics if the person is in ICU without any reason. So after that, the art of de-escalation you should know. Then started with meropenem and vancomycin. Culture is MSSA. So if it is MSSA, then we should not give vancomycin. So we should switch to cefazolin or enter anti-staphylococcal beta-lactam, because it is methicillin sensitive. So narrower antibiotic is often better than a broader one. Now next, our duration of therapy. So question is community acquired pneumonia improving after 3 days. So it is community acquired pneumonia and it is improving after 3 days. So should antibiotics continue for 14 days? Usually no. Modern evidence supports shorter duration in many infections. So not for 14 days. What is the shortest effective duration that you should look for? Now, for every antibiotics prescribed today, you should know drug like piperacillin tazobactam. So why it should be started for suspected sepsis. This exercise alone can transform the prescribing habits that which should be given. Then after this, in the evening session, know these stewardship targets, that Pseudomonas aeruginosa. Then avoid unnecessary anti-pseudomonal therapy. If it is Pseudomonas, give pseudomonal therapy. For Acinetobacter baumannii, avoid prolonged carbapenem exposure, because it really gets carbapenem resistance, easily develop this resistance. Then Klebsiella pneumoniae recognize ESBL and carbapenemase mechanism. So recognize ESBL and carbapenemase resistance mechanism. Enterococcus faecium, avoid treating the colonization. So what you can read and summarize, that what is the difference between colonization and infection, contamination and true bacteremia, difference between empiric, targeted and prophylactic antibiotic. So senior consultant should check every morning. One should ask, what infection am I treating? Do I still need the antibiotic? So these type of questions keep coming in your mind. These two questions prevent a large proportion of unnecessary antibiotic use and the foundation of becoming an excellent. So for this we want some cross questions, like if the person is ID fellow, then they have given fever, leukocyte count and CRP. So what we can learn about that? So fever is what should an ID fellow know. So this we are going to start in the next video.